Im Folgenden sehen Sie den Vortrag von Jona und Rob Janssen, beide Doktoren der Medizin. Rob Janssen ist Lungenfacharzt und translationaler Lungenforscher am Canisius-Wilhelmina Hospital in Nijmegen in den Niederlanden. Er untersucht den Stoffwechsel der elastischen Fasern bei Lungenfibrose und Emphysem. Jona ist Assistenzärztin für Innere Medizin, ebenfalls am Canisius-Wilhelmina Hospital in Nijmegen. Sie forscht zum Immunsystem und zur optimierter Infektionsabwehr. Beide Referenten sprechen gemeinsam über das Thema, welche Auswirkungen hat Vitamin K auf Covid-19 und dessen Verlauf. Aktuelle klinische Studienergebnisse rücken K2 in den Fokus. In diesem Zusammenhang werden unter anderem folgende Fragen erörtert. Was genau passiert bei einer Covid-19-Virusinfektion und welchen Beitrag leisten die Vitamine D und K2? Warum sind die Vitamin-K-Werte bei Menschen mit einer Covid-Erkrankung so niedrig? Drittens, wie begünstigt ein Vitamin-K-Mangel eine Thrombose und die Entstehung von schweren Lungenschäden?
Good day, everyone. My name is Jona. I'm a clinician training in internal medicine and a researcher in immunology and vitamin K metabolism. First of all, big thank you to the organizers for letting us talk. We will tell a little bit about our research on vitamin K and vitamin D in COVID-19 patients in our hospital in Nijmegen in the Netherlands. I will give the talk together with my colleague, Dr. Rob Janssen, pulmonologist with a broad experience in different lung diseases, including COPD and COVID-19. As I said, I'm a clinician in internal medicine with experience in infectious diseases and also now in COVID-19. And I'm accompanied by Margot Visser, who's a Ph.D. student who was doing her Ph.D. research in this area. So to start off the talk, I'm going to give the word to Dr. Rob Janssen.
In 2008, I finished my training as a pulmonologist and started as a medical specialist in the Canisius-Wilhelmina Hospital in Nijmegen. After a few years working there, I started a research project to evaluate the biomarker desmosine in COPD. Desmosine is a unique biomarker which is only found in cross-linked elastic fibers. The waves in the right upper figure represents elastic fibers and the hexagons represents desmosines. Desmosine levels in biofluids can be reliably quantified with LC-10-MMS. Desmosine levels in the bloodstream reflect the rate of systemic elastic fiber degradation in lungs, blood vessels, and other tissues. Plasma desmosine levels are increased in COPD patients. Rabinovich measured desmosine in 1177 COPD patients, and those in the highest quartiles had increased mortality during 3 years of follow-up compared to the other 3 quartiles, independently of several confounding factors. It took our clinical chemist almost 2 years to validate the LC-10-MMS desmosine assay in our hospital. The next step was to find an intervention to lower desmosine levels in COPD patients. We first assessed the effects of vitamin D on desmosine levels. 25 OHD levels, however, were not associated with desmosine levels. In the Belgian COPD trial, evaluating the effect of 1 year vitamin D supplementation on COPD exacerbation frequency versus placebo, we measured at baseline 4, 8, and 12 months and found no effect of the intervention on desmosine. I have to admit that I was a little bit disappointed in vitamin D and became interested in vitamin K. This is how we theoretically could link reduced vitamin K status to increased desmosine levels in COPD. Low vitamin K status leads to decreased levels of activated MGP. MGP is an inhibitor of calcification of elastic fibers, so reduced levels of active MGP may lead to increased calcium content in elastic fibers. It is known that increased calcium content of elastic fibers upregulates synthesis of proteases that have the ability to degrade elastic fibers. This may lead to accelerated elastrolysis reflected by increased desmosine levels. Direct quantification of blood vitamin K1 and K2 levels is technically feasible, but it is not useful as a biomarker of vitamin K status. It mainly reflects a snapshot of recent vitamin K intake. It is not an appropriate method to assess overall vitamin K status due to differences between vitamin K1 and vitamin K2 in bioavailability and half-life time. Vitamin K2 intake is usually too low to measure precisely. Furthermore, direct quantification of vitamin K gives limited information about vitamin K utilization in peripheral tissues. Measuring inactive levels of vitamin K-dependent proteins in the circulation is a valuable method for quantifying the combined deficit of vitamin K1 and K2. Matrix-Gla protein is an important protector of elastic fiber health. DPU-CMGP is MGP that has not been activated by vitamin K. High DPU-CMGP reflects low vitamin K status and vice versa. It is a surrogate biomarker of vitamin K status. In collaboration with vitamin K expert Kees Vermeer from the Maastricht University, we measured DPU-CMGP in a cohort of COPD patients. Measuring inactive levels of vitamin K-dependent proteins in the circulation is a good method for quantifying the combined deficit of vitamin K1 and K2. DPU-CMGP is MGP that has not been activated by vitamin K. So if you have high vitamin K DPU-CMGP, that means that there was not enough vitamin K present to activate all the MGP, meaning that you have shortage of vitamin K. If you have low DPU-CMGP levels, that means that you have enough vitamin K and are vitamin K sufficient. We assessed vitamin K status in COPD patients. A total of 192 COPD patients and 186 age-matched controls were included. On the y-axis, DPU-CMGP levels are depicted, and keep in mind that higher DPU-CMGP levels mean a greater vitamin K shortage. We found significantly increased DPU-CMGP levels in COPD patients compared to smoking and non-smoking controls. On the y-axis, desmosine levels are depicted, and on the x-axis, DPU-CMGP levels inversely related to vitamin K status. In contrast to with vitamin D, we found an inverse correlation between vitamin K status and desmosine levels. In an independent cohort consisting of 290 COPD patients, we categorized individuals based on DPU-CMGP levels and found that those in the highest cohort had significantly higher mortality than those from the other three quarters.
So I'd like to take you now from COPD to tell you a little bit about our research in COVID. So I started working at this hospital in Nijmegen in February of 2020. So I was there for about 3 weeks when we started to become overrun with this new virus. So for those who are not don't know the entire pathology, a very quick overview of COVID-19. So most COVID-19 is caused by a coronavirus, the SARS-CoV-2 coronavirus, and most coronaviruses, it's a whole family of viruses, and there's many that we're exposed to during our lifetimes. But most coronaviruses, when they infect someone, they only infect the upper respiratory tract. So they give you a runny nose, sore throat. But SARS-CoV-2 also infects the upper respiratory tract, but also the lower respiratory tract, and especially in the lungs. So what happens when the virus infects the lungs is that it causes an inflammatory response. The inflammation attracts macrophages. Macrophages are part of our first-line immune system, and they basically normally circulate in the blood vessels, and they leave the blood vessels to enter the lungs. And once in the lungs, they recognize that there's a virus infection going on, and they start to produce mediators like IL-6, to produce more inflammation, but they also produce other things, proteins called proteases, which, as Rob talked about, are there. One of their effects is that they damage surrounding structures, and they damage especially elastic fibers. And what happens when you look at the lungs with someone who has COVID, this is a CT scan, a type of scan of the lungs of someone with COVID. And you have to imagine you're standing at the foot of a patient, and the patient has just been sliced, with this being top, bottom, the back, thorax, and then you basically have a slice through the patient. So this is the left lung and the right lung, and you see that these areas that are black in this scan is air. So the lungs are supposed to be about this color. They're dark black, which means that there's air inside them. But you see these areas of whiteness, and this is these areas are turning white because they're more dense, because there's fluid there, and it's basically this diffuse inflammatory response, a sort of viral pneumonia, they call it, or acute respiratory distress syndrome if it gets bad enough. And this is the result of these macrophages causing inflammation throughout the lungs. So when we first started seeing COVID patients, this is what we were treating them for. They came in, they had respiratory distress. We would treat them with oxygen and intubation if necessary. But after a few weeks, we started to realize that it wasn't actually the only problem. Patients with COVID-19, a lot of them were actually having a second problem, which was that they were forming blood clots. And blood clots can occur anywhere in the body. When they occur in the brain, they're called a stroke. They occur in the heart, it's a heart attack or myocardial infarction. But they can also, these are examples of blood clots that are occurring in our arteries, so the blood vessels that go away from the heart towards the body. But they can also occur in the veins, which are returning the blood towards the heart. And when that happens in the lungs, it's called a pulmonary embolism. When it happens in the legs, it's a venous thrombosis. And all of these types of blood clots were seen in COVID patients. And we know that happens in people who have inflammation, who have infections, especially in people who are admitted to an intensive care unit with infections. But the rate in COVID-19 patients was really high. And it's still not entirely understood why this happens. So in the depths of this pandemic, when we were being overrun with patients, I met Rob Janssen, who you just heard about, who told me about vitamin K and about COPD, and also told me his hypothesis about the role of vitamin K in COVID-19. Namely, what this point that he made was, if you think about what is involved in both protecting the lung against damage, which we see in COVID, and in regulating blood clotting, vitamin K is essential for both of those things. And so we considered looking at vitamin K in our COVID-19 patients. So to look very quickly to explain the basis of this hypothesis, Rob, just to recap really quickly what Rob also explained, vitamin K, especially K1, it's absorbed from the gut and it goes to the liver, and in the liver it activates some of our proteins that we need to make our blood clot. Specifically, they're called factor 2, factor 7, factor 9, and factor 10. And this is what most clinicians like myself will know if you talk about vitamin K. You need vitamin K to make sure that your blood keeps clotting. People who have a very, 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 very severe vitamin K deficiency it will eventually be unable to clot and they will bleed. This is also how one of the drugs that inhibits blood clotting, the warfarin and other such related drugs, work. They prevent vitamin K recycling in the body, and so basically create a vitamin K deficiency. And in the end, that means that your blood can't clot as well. But as Rob already explained, that's not the only thing that vitamin K does. So after going to the liver, what's left of vitamin K can go to the other tissues, like the lungs, where it activates MGP, which is necessary to protect these elastic fibers. But it also activates other factors that are important anticoagulants. So factor 2, 7, 9, and 10, which I talked about, are procoagulants. So they make the blood clot. But you also have factors to prevent excessive blood clotting. And two of those are protein C and protein S. And protein C and protein S have to be activated by vitamin K in order to do their jobs. So protein C is made in the liver, so it's activated most likely together with the procoagulant factors. But protein S is made for about 50% in the liver and about 50% in the endothelial cells, which are the cells that line the outside of your blood vessels. So this vitamin K is also needed in the extrahepatic tissues in your blood vessels to help activate this protein S. Which is necessary to prevent your blood from clotting excessively, like we see happening in our COVID patients. So because it goes to the because it first goes to the liver where it activates these procoagulant factors and protein C, and then it's made available to the extrahepatic tissues. In times of vitamin K insufficiency, matrix GLA protein and anticoagulant protein S are affected before the clotting factors are. So if you start, for instance, if you give someone if you start giving someone a vitamin K deficiency, they first lose their matrix GLA protein and they lose their anticoagulant protein S before they lose their procoagulant factors. And that's important for the rest of the story that I'm going to tell. So what we did is we looked in 135 of our COVID-19 patients. We separated them into two categories: patients who were admitted to our ward, got supplemental oxygen, but were discharged without needing intubation and mechanical ventilation, and who, of course, were discharged alive, or the category of patients who got so sick that they needed intubation and mechanical ventilation, or that they died from COVID-19. And this separated out pretty nicely in 75 versus 60 patients, and we compared them to 184 healthy controls from a previous study. And the first thing we determined was DPUC-MGP, so inactivated MGP. And we looked at this in let's see if we can move this. We looked at this in our healthy controls, in patients who had a good outcome and patients who had this poor outcome. And what we see is that the normal levels, sort of indicating no vitamin or very little, not a real vitamin K deficiency, is 500 picomole per liter. So anything above this dotted line can be classified as vitamin K deficient. And what we immediately see is that every single one of our COVID-19 patients had a vitamin K deficiency if you look at DPUC-MGP, which is insane. 100% of these patients had this. And if you then compare patients between a good outcome and a poor outcome, you see that patients with a poor outcome had a more severely increased DPUC-MGP, indicating a more severe extrahepatic vitamin K deficiency. We also wanted to look at vitamin K, at a different vitamin K dependent protein, which is factor 2. So this is an assay called PIVCA2, which is also basically inactivated factor 2. So the factor 2, just to recap, has to be activated in the liver by vitamin K. And anything within this gray box, so under the that's lower than 0.15, is normal. And you see that the absolute majority of our COVID-19 patients fall underneath this gray line. So they have a normal activated factor 2 and don't have increased levels of inactive factor 2. You see that there's a very small percentage of patients that have high levels of inactivated factor 2, and there's no difference between good and poor outcomes. So basically what that means is that COVID-19 patients have normal intrahepatic vitamin K levels. So it's only in the extrahepatic tissues that this vitamin K deficiency is occurring. So the next question that we wanted to answer is, does this matter? So we saw very nicely the patients separating out, and good and poor patients, good and poor outcomes had a different levels of DPUC-MGP, but that we wanted to see if we could correlate this with some of the physiological processes, or the pathological processes, I should say, that are occurring in COVID-19. So we used the biomarker that Rob talked about, desmosine, which, just to remind you, is a factor for elastic fiber damage, shown here log transformed on the y-axis, and we correlated that with DPUC-MGP shown on the x-axis. And you see that there's a very strong correlation between higher DPUC-MGP, so increased vitamin K deficiency, and higher and more elastic fiber damage in these COVID-19 patients. So that gave us a very strong indication that there's a correlation with increased pathology. because this extrahepatic vitamin K deficiency correlates with elastic fiber degradation. So if we try and somehow put this into a model of what exactly is going on in COVID-19, this is the picture that we propose. So it begins, of course, with an infection with the virus, SARS-CoV-2, which infects one of your pulmonary cells, the AT2 cell. This results in activation of these inflammatory cytokines, these inflammatory processes, and these macrophages that then come into the lungs. They produce MMPs, which are a type of protease, which then damages elastic fibers. They get caught in the crossfire, basically, of your immune response. This partially degrades these elastic fibers, and here it comes back to the story about calcium. If there's calcium present and you have partially degraded elastic fibers, it'll bind much more easily. And this will, in turn, again, further damage the elastic fibers, and it ends in this cycle of damage. So to compensate, the body must upregulate MGP synthesis, but that in turn requires more vitamin K, which to be utilized for this MGP carboxylation. And these patients, they're not eating well because they're sick, and many of them are on supplemental oxygen. Some of them even can't eat. And we propose that this increased need for vitamin K, together with a decreased intake, results in this extrahepatic vitamin K insufficiency, because as I showed you at the beginning, if there's a shortage of vitamin K, it will first be taken up by the liver to activate the clotting factors. And the deficiency takes place mostly extrahepatically. This insufficient carboxylation of this pulmonary MGP then, of course, contributes to the pulmonary damage that we see in COVID. But it has a second effect, which is that if there's insufficient carboxylation of pulmonary MGP, it is very possible and very easy to imagine that there might also be insufficient carboxylation of this protein S, the anticoagulant protein that's synthesized in the endothelial cells. And that, it has been shown that decreases in protein S in our blood vessels result in increased thrombosis risk. You can see that in patients who have, for instance, a disease that means that they don't make protein S properly. They have a lot of increased blood clots. So it could very well be that this vitamin K deficiency is also linked to the blood clots that we see in COVID-19. At the moment, we can't show that, we can't demonstrate that yet, because there's not an assay to show, to distinguish between protein S that has and has not been activated by vitamin K. So we can't prove this yet, but this is the model that we think of how this could be playing out in the body. So besides vitamin K, we were also, of course, very interested in vitamin D. Vitamin D in COVID-19 is it's very good idea, or something to think about, because vitamin D, of course, is known for for having a lot of immunomodulatory effects, especially positive effects on inflammatory responses. And it's been shown in a previous study before COVID-19 that it was that better vitamin D status is protective against respiratory tract infections. So there's been a lot of talk about vitamin D status being associated with susceptibility to COVID-19, and much of this comes out of observational studies that show that countries with more sunlight and more UV exposure have lower rates of COVID deaths. But there's only been a few interventional studies that really test vitamin D supplementation against COVID-19, and those have actually shown mixed results, with some showing a positive effect and some showing no effect. So we thought that because in our cohort we saw such a clear effect of vitamin K in our good versus poor outcome patients, and it would be good to do the same thing for vitamin D. So we measured circulating 25-OH levels, again in these same, shown here on the y-axis, again in these same two groups of patients that had a good outcome of COVID-19 and patients that had a poor outcome of COVID-19. But we didn't find a difference in vitamin D levels between those patients. We also wanted to look at desmosine to see whether vitamin D had something to do with or had an effect on elastic fiber degradation. And the second graph here shows desmosine on the y-axis. And then we've divided the patients based on their vitamin D status into what's sort of commonly considered vitamin D sufficient. Here, vitamin D mildly deficient and very deficient. And what's very interesting is that we don't see that those who are vitamin D sufficient had lower rates of elastic fiber degradation. Instead, we actually see the lowest rates of elastic fiber degradation in people who had sort of this mild vitamin D deficiency. If then we try and do this analysis the other way, where we look at here at vitamin D levels log transformed on the x-axis, compared with elastic fiber degradation measured by desmosine log transformed on the y-axis, you see that there's not a there's no correlation between those two, which was maybe a little surprising, considering, of course, the body of literature that's circulating right now about vitamin D and COVID. So we thought about why not? And vitamin D is this good immunomodulator. We know that there's immune pathology going on in COVID-19. Why is vitamin D not coming out as an important factor in our patient cohort? In part, this is what we think. This is what requires further research, but this is our idea about it. It requires the distinction between disease susceptibility and disease severity, where susceptibility talks about, whether a person gets COVID-19 or not, and severity is about whether somebody gets very sick and requires mechanical ventilation, or whether someone only has mild symptoms. So if you think about disease susceptibility, vitamin D has a positive effect on the immune system, it might very well decrease your disease susceptibility by making it more difficult for you to be infected with COVID-19. But when we're thinking about disease severity, we have to consider other mechanisms, and we have to go back to what we talked about in the beginning. Why do we think people get this damage during COVID-19? Because vitamin D, of course, has a large impact on calcium metabolism, and if you have and it's been shown in I think in rats, if you give a high dose of vitamin D, it leads to a transient hypercalcemia. And that in turn leads to an upregulation of the production of MGP, probably to compensate for this increased calcium, which could damage elastic fibers. So we theorize that if you have sufficient vitamin D and it affects your calcium metabolism, it might actually it would require this upregulation of MGP to protect your elastic fibers. And if there's a deficiency of vitamin K, as we see in 100% of these COVID-19 patients, vitamin D could actually have negative effects on your elastic fiber damage, which we kind of see the suggestions of in the previous graph. So how do you compensate for that? Well, where we might want to have high levels of vitamin D for immune modulation to help with this disease susceptibility, but if it has a negative effect on disease severity, one way to compensate for that would be, of course, to combine it with vitamin K2 as a means for protecting elastic fibers. And then it could be you might be able to negate these effects on disease severity. This is a model. This is a hypothesis that we're currently studying. So to talk about what our future studies are going to be, I'm going to give the word to Margot Visser. She's a Ph.D. student and pulmonologist in training who will be doing a lot of these future studies.
Thank you, Jona, for your introduction. My name is Margot Visser, and I have recently started my Ph.D. trajectory at the 1st of January of this year. And I would like to elucidate our further studies and our clinical intervention trial. To investigate the similarities and differences between vitamin K and vitamin D on severe COVID-19, we've set up several studies. To start, our vitamin K study, vitamin K levels prior to COVID-19 infection. The data Jona just showed of the mechanism of pneumonia-induced extrahepatic vitamin K depletion leads to accelerated elastic fiber damage in severe COVID-19 due to impaired activation of uncarboxylated MGP. The question remains if the patients already had low vitamin K levels prior to being affected by COVID-19 or if there was increased utilization of vitamin K during the affected period. We want to demonstrate the levels of DP-UC-MGP in patients prior to COVID-19 infection. Besides this, we want to elucidate the correlation between both vitamin K and vitamin D on inflammation by trying to correlate it to IL-6, which is an important cytokine associated with disease severity in COVID-19, and MMP9, that is a protease in lungs. Furthermore, we want to evaluate the expression of carboxylated and uncarboxylated MGP in lungs of patients deceased due to COVID-19. What we have measured so far are insufficient markers in the blood, but we don't know if we can see the results in the lungs. Furthermore, we want to evaluate whether VCRC1 polymorphism modulates morbidity and mortality of COVID-19. In order to remain active, vitamin K needs to be continuously recycled by VCRC1. It is previously shown that polymorphism in the gene coding for VCRC1 is affecting the body's ability to recycle vitamin K. We hypothesize that a certain form of VCRC1 polymorphism is protective against thrombotic disease manifestations and may thereby be associated with lower COVID-19 related morbidity and mortality. Most important is our intervention study. Our aim is to demonstrate the link between vitamin K on pulmonary and thrombotic disease manifestations of COVID-19 through modulation of DPUC-MGP. We set up an intervention trial to study hospitalized patients with COVID-19, giving them either vitamin K or placebo. That will bring us to our trial. This is our COVID trial, named a Phase 2 double-blind, randomized, placebo-controlled clinical trial to investigate the safety and effects of oral vitamin K2 supplementation in COVID-19. We have a few objectives. We want to evaluate the effect of vitamin K2 on extrahepatic vitamin K2 status, measured by circulating DPUC-MGP. Besides this, we want to evaluate the effect of vitamin K2 on elastic fiber degradation as measured by plasma desmosine. Rob already explained this mechanism. Furthermore, we want to evaluate the effect of vitamin K2 on adverse events and disease progression and hepatic vitamin K status as measured by circulating PIVCA2, as Jona already explained. We want to reach it in patients, we want to reach our objectives, including patients suffering from COVID-19 requiring hospital admission. Then our study design and population. We want to include 40 patients of at least 18 years old. We are including both women and men. It is important that there is respiratory failure due to proven COVID-19 and that they are admitted to our hospital. They have to be able to swallow safely or get it via nasogastric tube. And the informed consent have to be signed. Then the conclusion of our presentation. Concluded can be said that desmosine is a good biomarker of elastic fiber degradation, and NPG is an important protector of elastic fiber health. Measuring inactive levels of vitamin K-dependent proteins in the circulation is a valuable method for quantifying the combined deficit of vitamin K1 and K2. Extrahepatic vitamin K deficiency correlates with increased elastic fiber degradation and poor clinical outcome. The effect of vitamin K on extrahepatic and hepatic vitamin K status will be evaluated in our COVID trial. So, these are the people involved in our investigations. We have two great research nurses, Britt and Karin, and our principal investigator is Tom Dofferhoff, and we are in collaboration with clinical chemistry, and this is Jody van den Ouweland, Henny van Daal, and Twan Beijers. And the first part of our study, we collaborated extensively with the University of Maastricht. We want to thank you all for listening to our presentation, and we would like to see your presentations and to share some results of our study. Thank you very much, and we will see you soon.